Good afternoon, and welcome to my presentation on the effects of Florida's pill mill laws on opioid overdoses in Northeast Florida. My name is Michelle Dedeo, and I'm an associate professor in the Department of Mathematics and Statistics and a Mayo Clinic research collaborator. This research presentation is part of a larger project that focuses on identifying statistical relationships between the opioid epidemic and socioeconomic and other relevant variables such as unemployment and income, crime, age and race, and estimated pill counts over time. The complexity and nuances of the opioid crisis spans public and private sectors that operate in very opaque environments with limited guidance. Here we apply data science and statistical methods to find relationships between that data that was recently made public by the Drug Enforcement Administration, or DEA, through their automated reports and consolidated ordering system, also known as ARCOS. ARCOS is a comprehensive drug reporting system that monitors the flow of controlled substances from their point of manufacture to the dispensing level. According to the DEA, more than 30 million transactions are reported each year to the ARCOS database. Between 2003 and 2010, Florida experienced a proliferation of pill mills, a category that includes physicians, pain clinics, and other providers that dispense large quantities of prescription drugs, typically for cash only, and outside of the scope of standard medical practice. These pill mills initially operated with limited state oversight. By 2019, 90 of the nation's top 100 doctors purchasing the most oxycodone nationwide were practicing in Florida. Florida adopted several measures to rein in the negligent practices of pill mills. These included 3 new state laws in 2010 and 2011, which substantially restricted prescribers' ability to dispense opioids at the site of care, and 2 law enforcement initiatives during 2010 and 2012, which led to the arrest and prosecution of persons operating pill mills violating the law. Since 2010, Florida has experienced substantial reductions in oxycodone purchasing physicians, opioid prescribing, and prescription drug diversion. A descriptive study by the Centers for Disease Control and Prevention showed dramatic reductions in overdose deaths following policy changes. However, that study did not use a comparison group or employ statistical techniques to account for potential confounding factors or secular trends. So, how can we verify this, and is it true? To determine the effects of these laws and interventions, we want to estimate the effect of the assumptions of what's known as a counterfactual by determining what would have happened in the absence of these pill mill laws and DEA interventions. This is done by testing 19 different state space smoothing models on time series of data that we'll look into further, and determining which model best suits the individual data set. Using those individual models, we then estimate the difference in overdose deaths by using the counterfactual and compare that to the actual overdose deaths. Then we estimate the difference in opioid pill sales by using the counterfactual to compare expected and disaggregated pill sales. Lastly, we determine whether the reduction in opioid pill sales is correlated to a reduction in overdose deaths using state space models. This project is special for several reasons. It involves a mix of disciplines, data science and computer science, using Python skills to extract and clean data sets, statistics and mathematics, using JMP and SAS packages to run statistical tests, and GIS and Tableau to create an interactive dashboard. In addition, our project focuses on the First Coast region only, which includes Baker, Clay, Duval, Nassau, Putnam, and St. Johns counties. The results are significant because the opioid crisis is ongoing and will keep going for the foreseeable future. Our project is also innovative in that no one has yet successfully analyzed the ARCOS dataset as it was recently released, and no one has done such a granular study of the opioid crisis in the nation. Several databases were accessed, cleaned, and analyzed for this research project. These include the ARCOS, which until recently was only accessible to the DEA, the Justice Department, and other related federal agencies. After a long legal battle in federal court brought by the Washington Post and HD Media, the Washington Post was able to release a significant portion of the database. The raw ARCOS data is available on the Washington Post's GitHub page. The ARCOS contains all controlled substances in all forms: pills, caplets, liquids, patches, etc. Unlike ARCOS data, which mentions details down to the address and date of a shipment, the DEA publishes quarterly reports which only capture a very broad snapshot of the transactions. The quantities are in terms of MMEs, which are morphine milligram equivalents, not as pills and liquids, as pills and liquids can all be dispensed in different strengths. The drugs themselves also have MME values. Hydrocodone has an MME of 1, and oxycodone is equivalent to an MME of 1.5. The census and ACS were also used. The ACS, or American Community Survey, is similar to the 10-year census, but is longer and is not required by every household to complete. It provides important social and economic measures necessary for our analysis. We use the database to determine population as well as poverty status and age status within each zip code. Lastly, the RUCA and RUC are USDA codes that classify based on zip or county, respectively, that quantify urbanization, population density, daily commuting patterns, and other measures. These codes were essential in our analysis, as they will be explained later. These values are whole numbers 1 through 10 that delineate metropolitan, micropolitan, small town, and rural areas. Assessing public health impacts not only requires access to this data, but careful academic analysis. First, we need to verify that there are fewer pills being sold. The sale of opioids before and after the passage of these laws went through drastically changed, but the true effect of this change in local communities has been hard to visualize. Previous datasets and measures served only as proxies for different aspects of the opioid crisis, such as Medicare Part D prescriptions, overdose mortality data, health plan information, and so forth, but none painted a complete picture of the epidemic. Throughout the process, the data extraction and cleaning of the ARCOS data was arduous. In addition to it being an extremely large data set, the ARCOS handbook, which is 191 pages long, was last updated in 1997. Up until this project, there was an open question on how to accurately count the number of pills and MMEs on the ARCOS. To give you an idea of the scope of the problem, the data for Florida zip codes beginning simply with the numbers 3-2 contained over 15 million records with 43 variables per record. That is essentially 86 million data points. There are 10 other opioid types reported in the ARCOS, but because they were shipped in much lower quantities, we excluded them from the study. The cleaning process that I created at the end of 2020 is for the entire ARCOS, and the data we were using includes the first coast, which is 60 zip codes, 320, 321, 322, and 2 from 326. Initially, this was over 4 million records, and I was able to clean it to 1.4 million records that consist of all sales of oxy and hydrocodone MMEs in the first coast. The next step was to verify this against the DEA's quarterly reports. The quarterly reports for the 320, 321, and 322 account for 3 data points in each quarter. So over that time span for each year, we only have 12 data points. The validation of the ARCOS data to the DEA quarterly was calculated via MMEs. As I mentioned before, the ARCOS data consisted of 1.4 million individual shipments and data points, whereas the quarterly reports for that 9-year span accounts for only 36 data points. Differences in the graphs can be attributed to issues such as delays in reporting shipments to the DEA, issues with ARCOS data, including multiple shipments or shipments within shipments, transaction types such as sales, returns, disposals, transfers, etc., DEA actions such as deletions and insertions, incorrect reporting of national drug codes, and much more. My cleaning methodology currently includes 15 steps, which I hope to condense over the next few months. The methods for doing this research include determining the areas of research, creating what I've called the adjusted RUCA score, and determining timing for each of these interventions. There are 60 zip codes grouped on the First Coast into 20 common area names. The regions were chosen by proximity and access to their nearest neighbors and labeled by their commonly known area names. Both NAS, Jax, and Mayport were removed as they serve the entire North Florida area. In creating the regions for analysis, we created an adjusted RUCA score for each region using two classification schemes, the RUCA and the RUC, and two balancers for areas with excessive poverty and areas with a disproportionate percentage of people over 65. To calculate the adjusted RUCA, we determine the RUCA score for each zip code, the 2003 RUC value, and the 2013 RUC value. The RUCA is determined every 10 years during the census, and all the values, the RUC and the RUCA, are integer numbers between 1 and 10. If the RUCA was less than the 2013 RUC, we took the average of the 2003 and 2013 RUC. If the RUCA was greater than or equal to the 2013 value, we took the RUCA. We added 1 point for every 50% increase in population over the regional poverty line, and 1 point for every 3% increase in the population over 65. The only area that added a point for percentage over the poverty line was Callahan, and for aged population over 65, we added 1 point for every 3% increase in 3 areas: Fernandina, Southwest Clay, and Outer Palatka. The maximum number of points an area could accumulate was 6. We ended up with 4 RUCA areas which create a semi-bullseye. RUCA 1, which is the major metro area of Jacksonville and Northeast Clay County; RUCA 2, which includes parts of St. Johns County; RUCA 4, which includes Fernandina, Callahan, McClenny, and Palatka; and RUCA 6, which includes Southwest Clay, Interlochen, and Crescent City. We identified October 2011, which is 2011 quarter 4, to be the beginning of the intervention period and the reference point for the counterfactual, as Florida's last major intervention took place in the prior month. We can see here that the DEA's Operation Oxy Alley was February 2010. The first pill mill law, which was State Bill 2272, took place in October 2010. Then Operation Pill Nation in February of 2011, along with the institution of House Bill 7095, and the Prescription Drug Monitoring Program in September of 2011. Here we can see the timing of events. It seems that the DEA's Oxy Alley placed the writing on the wall for the illicit providers who saw that their gravy train was coming to an end. Between the sting operations and the legislation that was pending in the state Senate and the House, there was a last gasp of pill sales, which relates to this giant spike. And then we see declines in pill sales. Just to hit home how many pills we're talking about during this entire time, we have over 680 million pills that were pumped into Northeast Florida between 2006 and 2014. To give you an idea how many pills that is, that equates to over 50 pills per man, woman, and child in Northeast Florida per year. But as we are about to see, the damage had been done, and we now come to the results of all this hard work in using the time series forecasting and the predicted overdose deaths. I tested 19 state space smoothing models on the overdose data in the 4 adjusted RUCA areas and to the entire First Coast in order to identify the best fit time series model, that is, the model with the lowest AIC or Akaki information criterion. Before you is the best model for the entire First Coast. The blue line represents the forecasted model, while the blue dots represent the actual overdose deaths. The alpha and beta are parameters that fit that particular model. According to all but one model, overdose deaths should have, at worst, remained the same after law enforcement and pill mill interventions. But this was not the case except in one area. Overdose deaths during the time Q1 2006 through Q3 2011, 23 quarters, was compared to Q4 2011 through Q4 2018, 29 quarters. We conclude that although the total number of pills sold has decreased over time, it has not resulted in a corresponding reduction in overdose deaths when compared to the counterfactual time series data, except in metropolitan area RUCA 4, which includes Callahan, Fernandina, Palatka, and Yulee. As we can see from the graph, in Metro Jacksonville and Northeast Clay County, we had a spike which occurred around 2015 of overdose deaths, which has continued. In St. John's counties, we see that approximately the number of overdose deaths has stayed the same as what we would expect. In the outer areas, the rural areas such as Interlochen, Outer Palatka, and Southwest Clay County, we have a huge variation in the number of overdose deaths over time. But in RUCA 4, we have a lowering trend of overdose deaths compared to what we expected through the model. According to the smoothing models, overdose deaths should have declined. Instead, the First Coast saw a net 673 more deaths than expected. For Metro Jacksonville and Northeast Clay County, we expect 390 overdose deaths by the models, but there were 1,318 during the 29 months following the last intervention. The greatest positive effect of the pill mill laws and interventions was in RUCA 4, which consists of the micropolitan areas of McClenny, Fernandina, Callahan, and Palatka. We actually saw a decrease in overdose deaths than expected of 410. If you notice, all models are represented by the 3-letter acronym, each standing for error, trend, and seasonality, respectively. A, M, and N stand for additive, multiplicative, or none. Sometimes an adjusted A or M occurs depending on the model type. In the model for the First Coast, the ANA, so additive error, no trend, and additive seasonality, 4-period model was optimal. I will also note that the sum of the net changes for each area does not equal negative 673, as the optimal model for the entire area was different than the individual areas in their respective error, trend, and seasonality. Overall, these results show that reduction in pill sales alone will not solve the opioid crisis. One major limitation in this study is the inability to account for the highly lethal fentanyl drug, which can be combined with opioids. Although fentanyl may account for a portion of these excessive deaths, there is no known way to account for it. This is a screenshot of the public Tableau dashboard. This online interactive dashboard was created to help the public visualize the data and download the data. By using Tableau, it gave us the ability to filter on demand by region, zip, adjusted RUCA, and other custom areas. Simple clicks allow you to dig deeper into the underlying data, and lastly, it's publicly available and easily downloadable into a CSV. The elements in each graph have different functions in terms of visualization, and this graph is fully accessible in terms of filtering what you want to analyze, be it region, time frame, etc. All datasets are available on the website itself, so anyone who wants to delve deeper into the dashboard can do so. The link is in the references. I'll be continuing this line of research for the foreseeable future, so please visit the dashboard regularly for new features and visualizations as they occur. Thank you for listening to this presentation, and thank you for your time. If you have any questions, please don't hesitate to email me at mdadeo@unf.edu.